Today our topic of the lecture is complex amalgam restorations. This is Dr. Masab. You are listening to me. Thank you for coming to my channel. What makes the amalgam restoration complex is that they have increased structural loss. You have gone further away from class 1 GV black and class 2, class 3, class 4 GV black restorations. Now tooth is missing one or more walls, or even the height of the crown is reduced either by attrition, abrasion, or something like that. So more than one wall is being restored, the crown height being increased is called complex amalgam restorations. The learning objectives of this presentation or lecture will be you are able to define what are complex amalgam restorations, identify what additional retentive features you can use, identify the clinical scenarios in which you can use additional retentive features, and you are going to demonstrate step-by-step clinical procedure to do the complex amalgam restoration. Why and where we are going to do these complex amalgam restorations? Why we are going to do these complex amalgam restoration is that we are a third world country, so the patient cannot always afford the fixed type of or more advanced restorations such as implants, so we are going to use it in the posterior teeth in replacement of crowns, and they are very economical. They can be used as a foundation before placing a crown, and there is extensive caries. Isolation is a problem. You cannot use rubber dam isolation. Then amalgam is not very technique sensitive as compared to composite. Where we cannot use these complex restorations is that they are aesthetic areas, and the substrate for these additional retention features of the complex amalgam restorations is not very good, and patient is not very motivated for the oral hygiene to be maintained to the high standards after these restorations are provided. One of the type of additional retentive methods we are going to use here are slots. Slots are the horizontal grooves which are wider at the base and converge occlusally. They are up to 1 to 2 mm wide at the base, 1 mm at the occlusal portion, 1.5 mm. They should always be placed around the line angles, 3 to 4 mm in length. They are horizontally placed grooves in the dentine. There are 3 mm or 4 mm in length, always placed at the corners of the teeth, minding that they should be 1 millimeter away from the dentino-enamel junctions, as you can see in the pictures on the left and on the right of the slide. There is a number 330 burr placed here as a reference. Now we have discussed that when the tooth structure loss is up to 2 mm, and we are going to use additional features such as slots. Slots are basically the horizontal grooves in the tooth placed at the line angle, such as mesiobuccal line angle, distobuccal line angle, mesiolingual line angle, distolingual line angle, or distopulpal and mesiopulpal line angles. They are 4 mm in length, such as you are placing it like this, 4 mm in length, and 1 mm away from the dentino-enamel junction, and you are going to place them in approximately 2 mm wide apically, and incisally or occlusally it is 1 mm converging occlusally. Increasing the length or increasing the depth of the grooves will not cause any increase in retention. Moving on, you still need more retention. More of the walls of the tooth have been lost, so you are going to use retentive pins. These are also called Dentin pins or parapulpal pins. Retention is increased very dramatically in these when you are going to use it in conjunction with amalgam, but there are risks when you are preparing pin channels. You can encounter sensitivity, exposure of the pulp, and grazed lines or fractures of the tooth if you are not very careful when selecting the size and number of the dentin pins. As you can see in this diagram, there are 3 types of dentin pins. First of all, there is a cemented dentin pin. Cemented dentin pin should always be smaller than the channel you prepared for the pins by 0.025 inches. Then you have serrated pins, which are also type of cemented pins. Then we have the self-threading pins. For the self-threading pins, the channel you are going to prepare, it should be slightly smaller so that the dentine pin can thread into the dentine. The most common type of dentine pins for amalgam restorations is the threaded type of dentine pins. For the composite type, we are going to use cemented fiber resin and other type of carbon fiber dentine pins. On the right, you can see there are first two types of the dentine pins which can be used with the hand wrench, the TMS system, and the below C and D type of dentine pins can be used in the plastic sleeve, and the plastic sleeve is used with triangle slow speed handpiece. These are the threaded dentine pins on the right. How are we going to place dentine pins? Now you have studied about the slots and dentine pins. How we are going to place dentine pins? Here again you can see we have got number 330 bar. You will be thinking that number 330 bar is a hot favorite. Yes, it is. So we are going to produce first a pilot hole in the dentine where we have placed where we are going to place the dentine pins. When the pilot hole is placed, you can see there are pin channel drills with color codes and the dentine pin attached to the slow speed handpiece attachment. You are going to select any suitable size you want. We will discuss it further which suitable size is going to be used in which place. Then you will place it in a slow speed drill. The drill will be used to produce the full length of the dentine pin, that is up to 2 mm in the dentine, and the 2 mm will be left for amalgam or any restoration retention. Then the dentine pin is placed via using the hand wrench or the slow speed handpiece. You can see when the dentine pin is placed by these methods, it has gained sufficient depth in the dentine and you are satisfied that it is not reaching the pulp or not exiting outside causing perforation on the side of the tooth. You can trim them or shear them using a small size round burr in a fast handpiece. But you should grasp the free end of the dentine pin so that it does not fly away and cause injury to the personnel, your dental team nearby. So let us look at the factors we need to consider before we are going to put the size and the number of dentine pins. You are going to use very big dentine pin, very small dentine pin on the mesial side, on the distal side, 2 dentine pin, 3 or 4, how many you are going to need. Now we are going to look at that. The things which will increase the retention of your complex amalgam restoration by using the dentine pin is the type of dentine pin you are going to use. If you are going to use the self-threading type which has threads on it, it will increase your retention more than the cemented or the serrated type of the dentine pins. Similarly, if you are the more dentine pins you are going to insert into the dentine, the more retention you will get. The bigger the dentine pin in diameter, in its width, the more retention is increased. But ideally a dentine pin should equally be into the dentine and into the amalgam. So that means that if your dentine pin is going to be 2 mm in the amalgam, it should be inserted into the dentine by 2 mm at least, so that it does not get dislodged when you condense amalgam or you do something else. Now we are going to look at the pin placement factors. The pin placement factors is the pin size. The bigger the pin size, you are going to produce a larger, not according to the diameter but 0.025 inch smaller than the self-threaded pin. The channel will be larger and you should not put it at the concavity on the mesial side of the upper premolar and in the interradicular area of upper molars which have 3 roots, and the pin number should be dictated by the amount of dentine available. If you have three walls of the tooth, you cannot place dentine pin everywhere in where the tooth walls are present. You will only place one or two dentine pins where the tooth wall is missing, such as if we have a lower or upper premolar, it has four walls: mesial, distal, buccal and lingual, and a mesial wall is missing. You are going to place only two dentine pins considering any concavity on the mesial side of the root. One dentine pin will go on the mesio-buccal line angle, the another one dentine pin will go at the mesio-palatal line angle, considering the concavity present on the mesial side. And the pinhole should always be directed along the external surface of the tooth. It should always be concentric. For example, the tooth always converges below the cemento-enamel junction and towards the cemento-enamel junction. Your dentine, the tooth is converging like this. So your dentine pin should not be going this way. It will perforate out of the side of the tooth, and it should always be angulated toward the inside of the tooth. The diagram on the right is going to tell you how to orient your dentine pin drills so that you do not perforate externally, or you do not perforate the pulp if you are going too deep for a bigger or longer pin. The risk of pulpal perforation is most significant in the mesiofacial or mesiobuccal corner of upper and lower first molars, upper sixth and lower sixth. And if you find that a tooth is rotated in the arch, tooth is tilted in the arch, there is going to be a significant risk of causing the pulpal exposure. When pulpal exposure is happened, usually your pin is not going to be as retentive. Try to remove it, place MTA or reparative dentine, smart dentine replacement, SDR material or biodentine over it, then place RMGIC. Try to observe the tooth for any pulpal symptoms to occur, then proceed with your complex restoration. And if you have placed a dentine pin that is not really useful to you, you have placed it too close to a wall, so you cannot condense amalgam around it. So for example, your dentine pin is here and your dentine wall of the tooth is here. You cannot place amalgam here. So you are going to use a drill such as number 330 bar to make a space around it for amalgam to be condensed around, and let it be buried in the amalgam. Use another dentine pin in another place for retention requirements you have. Diagram on the left, we are going to show you that this is a type of self-shearing pin. The self-shearing dentine pin, you place it in a slow speed handpiece and it has 2 or 3 pins joined all together. You have placed a pin channel by number 330 bar. You have used the drill to make the pin channel. Now you are going to place the pin via the slow speed handpiece, and while the handpiece is rotating and the pin has reached its channel at the bottom, it will self detach it first from the slow speed handpiece attachment. On the right side, you are being shown there are minutia type of the pins of the thread made system, the most common type of the system at the time of publishing of the stud event art and size of dentistry. And you can see there are 2 attachments, attachment A and attachment B. Both attachments are used for these TMS type of the pins. One is for the self-shearing pins, link plus pins, and the other is for link series pins. And the book diagram tells you that they are freely revolving in the slow speed handpiece. It does not detach. Now we are going to come at the other type of the pin insertion method. There are 3 sizes or 4 sizes of the thread made system pins. You can see the minikin, that is 0.48 millimeter in diameter. The minikin pins are very small. They are not very retentive in the posterior teeth. but they are used seldom in rarely used in anterior teeth because they are metal colored. In the composite restoration they will show through. Then we come to the minim. If you have prepared a whole pin channel that is slightly larger than the mini kin, so there comes the minim as a backup plan. You have pin channel is wider than the intended hole or the intended pin channel, you are going to use the minim pin. Then we come to minuta pins. The minuta pins are most commonly used in the posterior dentition. The regular pins are most commonly used with these hand wrenches. They are too big to be used in current clinical scenarios and most rarely used in 1 in 1,000 times. We are coming at the clinical use case. So you have two types of the retentive methods for the complex amalgam restorations. You have pins and you have slots. The pins are used when the tooth has four walls like mesial wall, distal wall, buccal wall, lingual wall. And when the patient comes to you, out of the four, only one wall is remaining. The mesial wall or a buccal wall or distal wall, and all three of the walls are lost. But ideal decision making and your diagnosis and treatment plan states that either you are going to do a foundational restoration so that the patient can receive a crown, or your patient belongs to a third world country, so he does not want any implant restoration after the extraction of the tooth, so you are going to proceed further with the complex amalgam restoration. Now you are going to place pins at the missing walls axiopulpal angles you can see on the right side. In other cases where there are walls present but the height of the tooth is reduced by any reason such as attrition, tooth preparation for endodontic restoration or anything like this, you are going to use slots. The tooth has walls but height is reduced, so you are not going to use pins to cause further problems. As for the pins, you are going to need 2 mm occlusal surface above the tooth, above the pin, sorry, so it is not available. The height of the tooth is already reduced. You are going to use slots. Now we are going to do the complex amalgam restorations. All the diagrams placed in this presentation are coming from second South Asian edition of Sturdivant's Art and Science Dentistry. All the copyrights are owned by the publishers and their respective which doctors who have done these fabulous restorations. As you can see in this diagram, the patient is missing the mesiolingual cusp, and the arrow shows on the down that you are going to remove the restoration. You have prepared the tooth by preparing it for the cusp capping in the bottom left corner, and you have removed all the previous linings such as zinc phosphate or the base, anything which was that. And in the arrow which is looking at the up in the middle, it is showing you that we are going to place the liner such as RMGIC or anything such as zinc oxide, zinc phosphate. In amalgam's case, it is placed. After that, we are going to produce the pilot hole. You can see the small round burr at the mesiolingual line angle according to this diagram. Then in the bottom right diagram, the pin channel is being prepared using the slow speed handpiece and the appropriate pin drill. Then on the diagram to the right, we are placing the actual pin into the dentine using the slow speed handpiece in the axial line angle. Continuing forwards, you can see the pin has been placed. Now in the bottom left, we are reducing the pin to the appropriate size so that amalgam of the 2 mm thickness can be condensed over it. Now you can see the two pins are placed and two wedges are being placed around it to separate the tooth from adjacent teeth and make appropriate contacts. Then the matrix band, in this case the Toffelmayer matrix band has been placed in the middle diagram under the blue box. Proceeding of the amalgam placement, such as condensation of amalgam, we have produced the over condensation. Then it has been carved, burnished, and the matrix band has been removed on the top right corner, and it has been polished after that in the bottom right corner. Such a fabulous restoration. Now on the topic of Toffelmayer retainers, the retainer placement is a big problem. The tongue and the cheek and other things are the problems in the placement of retainer. It can frequently be dislodged. We have now been introduced to the automatrix and the sectional matrices. Automatrix is the most widely used matrix band now, because it has removed the retainer. It can be placed lingually or buccally, the pilot hole of this matrix band. It can be locked, but there are certain problems. It is not very easily burnishable, it cannot be modified, and there are cost problems. As you can see in this diagram, there are three parts: the activator 3 as they call it, the matrix tightening device, and the matrix band. You can see in this diagram provided by the dent supply, you can see matrix band is in position on the lower first molar, and it has a compound class 2 cavity prepared. Thank you for listening to me. Do like and subscribe.